Well, I hope everyone enjoyed that opening music that our speaker chose himself. And I might let him tell you a little bit about his choice of the song. But first, I'll just say that I'm happy to see everyone here on Zoom, those of you who have your cameras on, and even those who don't. And to say, I hope everyone is enjoying the beginning of fall here. It is starting to get a little bit chilly and it's finally starting to feel like it's fall. So we're just so excited to have Andrew Anderson, who is going to be speaking to us today. But what, as in true fashion with the Health Equity Jam session, we're going to start with sort of some informal fun facts, and then we'll move more into the, the formal traditional academic introductions. So, well, first, Andrew, tell us a little bit about your choice of music. I love Bob Marley, by the way, one of my favorite artists, but we were just chatting right before everyone else got on. And so I wanted you to just share a little bit about, what that song means to you and why you chose it.
Yeah. Hi, everyone. Nice to meet you. Thank you for having me. This is my first time in one of these jam sessions, and I will definitely be continuing to come to them. So I'm a first generation Jamaican immigrant for one, so I grew up with the sounds of reggae in my household. But this particular song has always meant a lot to me because it's actually almost word for word from a speech from Emperor Selassie from Ethiopia. He gave this speech to the UN General Assembly in 1963. And I thought how fitting for a health equity jam session when it's all about equality and justice and racial equality specifically. So, and also Bob Marley is a well-known Jamaican export. So
Really? Yes, just an icon and a true gift to the world. So thank you for telling us about that. So we're going to continue with some fun facts about Andrew. So he and I have, common or similar music preferences and interests, but some of his other hobbies are not necessarily things that I'm that good at, but maybe there's some others of you on here who would identify. So one of his hobbies is, I would say, a little bit more athletic. So does anybody have any guesses about what that might be? We have, oh, someone came up with pickleball. Ah, I
it's
see
more exciting than it actually is.
scuba diving, rock climbing, and frisbee and basketball. There is actually a winner already. So ding, 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 there's a winner. Did you see the winner,
Oh, I
Andrew?
see. Yeah,
Yes.
yeah. The second one, it looks like. Yeah, running. Yeah. Because I can do that on the water. I live in Fells Point, so if you live down here, you might see me.
Are you a morning or evening runner?
I'd say mostly a morning runner, but sometimes I don't get started early enough, and then I'll do it around duskish or at
Mhm.
night. Yeah.
Yeah, yeah. So you're like a diehard, like whenever you can fit it in, you're going to be
Mhm.
out there. Yeah.
Yeah, because I need it sometimes just to sleep and to calm my mind. It's like a mental health thing for me.
Mhm.
So yeah, feels more like that than physical these days.
Awesome. Awesome. Well, to sort of balance that out, you have another hobby, which is kind of close to something else I like to do. So, well, tell us, well, actually, I'll share what it is and then you can tell us. You said one of your hobbies is cooking. So, who doesn't love a man who likes to cook? So, tell us more about what you like to cook.
I cook a lot of things, so pretty much anything that I feel like making is sometimes and I'll try out different like cultural dishes. So for instance, I got really into uh making like a Japanese breakfast. So I've got like a special omelet maker and I practice making different types of Japanese omelets, adding some sort of like fish protein, edamame, different types of things. But yeah, I cook a lot, which was also nice because I was in New Orleans for 3 years, and I also had picked up a lot of recipes while I was there from colleagues, and I think I can make probably some of the best mac and cheese now
Mm,
from being there.
yeah,
But yeah, I like cooking also. Yeah, I can cook oxtail. I see that in the chat. It
awesome.
takes a
Yeah.
little while. I like stews, so oxtail is a good one because you could just like leave it and forget about it.
Yum. Well,
Yeah, curry
not
chicken.
quite,
I can
not quite.
definitely cook all the Jamaican food because I've cooked that my whole life pretty much since I was a teenager.
Oh, awesome. One of my favorite genres, or I guess it's not called genre for food.
Cuisine. Or, yeah.
Yes, cuisines. Yeah, love that and love to eat, of course.
Yeah, me too. That was one of the major draws of going to New Orleans.
Foodies. Yeah.
Yeah.
So anyway, it's not dinner time yet, but so I guess I'm sure we're making everybody hungry right now. So anyway, so you've got one more hobby that is something that I can relate to. I like historical movies and TV series. I always like to imagine what it's like to live in a different time, but you have a slightly different hobby that is related. So tell us more about what you like to read. You said you told us that you like historical fiction. So tell us about that.
Yeah, this is probably a little bit different. So I like novels that are set in different time periods. Actually, one of my favorite books, which is probably unusual, is Middlemarch by George Eliot, which is a really long book, and it's set in the early 1830s, and she wrote the book in the 1870s. But it was I don't know, it just had a really big impact on me. And it's weird because it's a completely different culture, right? It's set in England in a countryside. But it's almost like it's like reading a sociology text
Mhm.
on, human experience. And it's amazing how similar, these characters feel so real, and they face the same issues that we all face. So it's
Yeah.
it's great. I've read it a couple times.
Oh, awesome. Well, I'm going to invite people to put in the chat some of your favorite historical fiction books or novels, just in case Andrew wants some recommendations
Yes, please.
what to read next. So I'm going to move into introducing you more formally, so people know that we're not here just to talk about food and running and books, but we are here to talk about health equity as well. So Andrew has a PhD. He is an assistant professor in the Department of Health Policy and Management at the Bloomberg School of Public Health. And he studies the role of payment policies in shaping healthcare access and outcomes, particularly for groups facing disproportionate health risks. Before joining Johns Hopkins, he was an assistant professor at Tulane University in New Orleans, where he was a research scientist and a Phyllis Torta Healthcare Quality Fellow at the National Committee for Quality Assurance, NCQA, and also director of quality measurement at the National Quality Forum. So that's exciting. I've actually done work with both of those organizations, but I think it's great when you bring in sort of that real world perspective into academia, and it helps to make your research definitely very practical and actionable. So anyway, Andrew has also been a Robert Wood Johnson Foundation Health Policy Scholar and a Robert Wood Johnson Foundation Health Equity Scholar for Action. So without further ado, Dr. Andrew Anderson.
Thank you. And thanks for the book recommendations in the chat. I'm still looking at them. Yeah, I haven't heard of some of these. Oh, Count of Monte Cristo is great. I know a lot of people, that's their favorite. Let's see. I will share my screen.
Oh, I forgot to mention that I had the honor of co-authoring a book chapter with Andrew recently. So, and
On this topic too.
on this very topic, yeah. So,
Yeah.
okay,
Uh, so
take it
thank
away.
you. Um, so yeah, so I guess the title of this talk is Building Equity into Healthcare Quality Measurement. And I already got a good introduction, so I can skip over this part. But I wanted to just talk a little bit about some of the questions that motivate my research and just generally why I think this is important. So there are kind of four areas. One is, how does performance-based payment? So a lot of us, we've heard of, and I have a couple questions for you all too, is, how does performance-based payment influence healthcare disparities? And how does linking payment to performance actually exacerbate or, promote health, well, exacerbate health inequities or promote health equity? Also thinking about measurement design. So how do we build measures in a way that allow us to capture the extent to which we're reaching or towards health equity? And also the types of thinking about measures not as just a way for monitoring progress towards improvement in the health system, but also incentives for health care providers, for health plans, for different actors in the health system to improve. So, and then lastly, the actual provider behavior as a result of the measurement incentives, because we don't just, measurement is a tool, but it also, it sheds light on areas where improvement needs to happen, and hopefully we can attribute that what needs to happen to specific actors, right? So the general overview for the session is, first, I'm just going to talk about the role of quality measures as a policy lever for improving healthcare equity, specifically healthcare equity. And then part two, I decided to just chat about a project that I have in progress, actually funded through the Hopkins Business of Health Initiative, a pilot project on Medicare Advantage and rankings of plans, because of some changes that are happening in the coming future to how CMS star ratings are calculated. It's called the Health Equity Index, which I'll talk about shortly. So first, I just kind of wanted to get a temperature check of the room. I see some folks in here that I imagine are very familiar with quality measurement and, and quality measures, but I'm just curious, what do you think of when you hear quality measurement, and, how have you used it in your work? And I don't know if maybe we could go off mute if you'd like, or you could just drop it in the chat. Am I still sharing? Did I drop it?
Yes, you are. You're
Okay.
sharing.
Okay.
I don't know if are there answers in the chat. I know I will say, well, whenever I hear about quality measurement, I definitely think about healthcare executives and leaders and people who are kind of trying to keep, as a physician, thinking of making sure that I'm like doing what I'm supposed to be doing. So I definitely think about that. I see Dr. Golden, Sharita Golden has her hand.
Oh, yeah.
No, hi, Andrew. No, glad you're talking about this. When I think of quality metrics, I think of those measures that hold the clinicians as well as the systems accountable for ensuring high quality care and safety for patients, as well as being a lever to help with to facilitate that behavior through like the reimbursement structure. But I mostly think about it as a way to ensure equitable, high quality care for patients.
Oh, yeah. Yeah, I think about it the same way. And I'm seeing a lot of and thanks for that response. I'm seeing a lot of responses here in the chat too that are similar to what you just mentioned. And some people are even using, which I'll just glance over later, the structure, process, outcome, data median framework, built-in evaluation measures to improve the best delivery of services and care, Angela. Quality measures uniform across health systems and states. So there's some sort of, I'm also getting a theme here of some harmonization or movement towards similar goals, and measures allow us to do that. So great. I see HEDIS stars. I'm glad some folks are familiar with that, measuring performance based on a standard or benchmark. So benchmarking is also really important. And sometimes when you refer to benchmarking and quality measurement, we're thinking about how healthcare entities, so it could be a hospital, hospice, outpatient care, skilled nursing facility, might be monitoring its own quality and then looking at how that quality improves over time or doesn't improve. So great answers. Let me just jump back. So good. I can now have a better sense of where you all are here. All right, so I'm going to briefly just walk through this a little faster on some of this since we've chatted through it, but some of the types of healthcare quality measures, some of you mentioned, structures of care, which again is, accreditation might be a thought of a structure, appropriate staffing. There's processes of care, which we're thinking about all the time, like colorectal cancer screening, breast cancer screening, BMI. And then outcomes can be further defined. Sometimes we think of them as intermediate clinical outcomes, which are things like, HbA1c values, right? So it tells us something about, risk for diabetes. There's also the ultimate outcomes like mortality. We have sometimes hospital-acquired infections is considered an outcome. Less often we think of patient-reported outcomes, also very important. Functional status, patient experience. And then we have some others that don't really fall under the domain of quality, but are also important, which are resource use and cost measures and efficiency. And actually was going to chat a little bit, but maybe in another talk sometime, about some of the tensions in the literature in some articles where they emphasize tensions between equity and efficiency. Can we have an efficient healthcare system and also have an equitable one? Which I argue that we can, and it's the only way. And so what I started to mention is quality measures are tied to hopefully accountable entities. So again, hospitals, nursing facilities, health plans. And in the healthcare system, these are, again, what we use to try to drive improvement. In broader public health and health policy discussions, we think about more population level measures where the county might be responsible, when you think of the preventable hospitalization measures or, suicide rates, the state or the country, you sort of roll it up to higher and higher perspectives and more people, and it gets more complicated, the number of people who are involved in order to solve a particular issue. So throughout this, I'll be using both different types of words to refer to the same thing. So sometimes you'll hear performance measures, you'll hear quality measures, you'll hear metrics, you'll hear indicators. Some people define them differently, but a lot of the time they're used interchangeably. So I kind of jumping right in, typically we haven't thought about health equity as a distinct performance measure or developing performance measures to see whether or not we're moving towards health equity as a goal of the healthcare system. But it is important, as everyone in this room knows, because it encourages, as I said, providers, health plans, et cetera, to address health disparities and try to move towards health equity. But it also creates a signal that health equity is an important component of the healthcare delivery. And but the tensions also come into play, which I'm sure maybe you've seen this in your own work, is like, how do we actually measure health equity in healthcare? And more broadly, just the question about how do we measure health equity, period, especially as definitions have changed over time. I wanted to also bring attention to this framework as some context for this talk, which is a framework that you may all be familiar with now because it's pretty old. I guess it came out in 2017. Maybe some of you even were involved in the development of this, but this is a framework looking at how social risk factors impact performance measures that are used in value-based payment programs. And I guess a brief definition of value-based payment is just that we pay, rather than paying for volume of services, we pay for the value that we're getting out of the system. So the bottom line is performance measures or indicators are a mechanism by which we can determine whether or not we are getting high value from care. And there are many different definitions of value. I just dropped this slide in here because I went to it. There is a lot that's been happening over the last 4 or 5 years. Well, I mean, longer than that, but especially in the last 4 or 5 years within the Centers for Medicare and Medicaid Services, trying to think about, especially since the executive order from the Biden administration, to try to include equity in some dimension or considerations across federal agencies. And so the CMS is officially, and it looks like some of you are familiar with the Star Ratings program. Star Ratings rank health plans according to their quality. And CMS in the 2027 Star Ratings, which is actually going to be this performance period of 2024 to 2025, they're going to be including a health equity index. And this index is going to be tied to many millions of dollars for plan contracts and actually putting at risk money for not improving or reducing disparities within these groups. And in the picture here, these are some of the 12 quality measures that they're using within this index. So it includes things like breast cancer screening, colorectal cancer screening, medication adherence, diabetes care measures like eye exams. And so this is a big deal because this is the first time, at least that I've known, that we really see them putting money out there at risk, so that it's showing a real priority. The downside is that it is only focused on, well, I mean, it is an opportunity. It's good. We're going to trying to reduce disparities among people living with disabilities and people who are low income, and maybe potentially expanding in the future to other demographics that experience disparities. But it is a positive sign. So, and just in summary, so most of our current quality measurement initiatives, while well-intentioned, overlook health equity. And now a typical approach to measurement, it will generally assess the quality of care for the entire patient population or member population, or however you want to define the group. But it often misses out on the nuances that affect specific, more historically marginalized groups. So in this example, if you want to consider Medicare patients eligible for colorectal cancer screening, which is one of the measures that are both used in many value-based payment programs, a significant portion of the people who are eligible for this measure, and when you're thinking about these are older adults, they're going to be white, they're going to be non-disabled, and they're going to live in metropolitan areas. And actually, I put on the slide here about 90% white, 85% and 70% respectively. So given these numbers, it's natural that, say, a health system might focus their efforts on these larger groups because they represent the majority. But by concentrating, as you all know, on these groups, providers might inadvertently neglect or underserve other patient segments that could be at greater risk and have different needs. So the question we have to ask ourselves is how we adjust our measurement strategies so we ensure that every group, especially those that are most at risk, is getting the attention that they deserve. And we really have to think about this, especially as we're shifting to these new opportunities to improve the healthcare system. And I'm not looking at the chat, so let me just make sure that nobody's putting anything in there. Okay, good. I haven't lost anyone. So I'll just briefly talk about some of the common approaches for measuring healthcare equity, keep emphasizing healthcare. So the first is stratification. So this is a method by which we break down data into different subgroups, and by disaggregating patient data into specific subgroups, we can create performance rates for that specific subgroup. So we can see the individual performance of colorectal cancer screening for a health plan for the dually eligible population who's eligible for Medicare and Medicaid, so low income older adults. And then we also have the direct disparities measurement approach. So this goes straight to measuring the differences in outcomes between groups. So we might want to compare the health outcomes of patients in rural areas who might be more disadvantaged to those in urban areas that maybe have more social advantages, and just look at the percent difference in the rates, or the absolute difference in the rates. So most of the time, our current approach is focusing on one of these dimensions, like race or geography, or income, but we may need to consider whether these single dimension approaches sufficiently capture the full picture of healthcare equity, or if they might be oversimplifying the complex interactions between various social risk factors, as I showed you in that conceptual framework before. So the problem with the single dimension approach. So patients often face multiple challenges that contribute to health disparities. So they have a constellation of relevant characteristics. They're not just their race, they're not just their household income or where they live. So while stratified scores help us monitor these disparities on these different dimensions effectively, the real impact comes from aligning measurement incentives with policy goals. And so if the incentives don't specifically support reducing disparities, improvements may only benefit the largest or most accessible groups and neglect those at most risk. So this is why the Health Equity Index is a step forward, because it incentivizes health plans, I think Medicare Advantage plans specifically, which are the private option or alternative to traditional Medicare, to improve or reduce disparities, I should say. So what are some
Dr. Anderson frozen?
Yes,
Yeah,
it seems so.
I thought it was me.
I think he is, yeah.
He's frozen. Oh dear. There are a couple of people look like they're frozen though, not just him. Let's see if he's back. Oh, he's coming back.
Oh, did I
you-
cut out?
Yes, you did for just a couple of minute there.
Whoops. Oh, I see now. It says your internet connection is unstable. Sorry. Where did you lose? Did I lose you?
Let's see. Well, why don't we take it from the top?
Okay. On this slide or the previous one?
This slide, this
Oh,
slide.
okay, great. Okay. So I was talking about the unintended consequences of focusing on rewarding performance for reducing disparities on single dimensions or in any one group. So you might find that, for instance, the Black population in the United States are disproportionately in urban areas or around urban centers. And if you decide to focus improving quality of care, say reducing the disparity between rural urban populations, and you divert resources primarily towards the rural population to reduce disparities, you may inadvertently redirect or take resources away from the Black population if you're only looking at one dimension. So there's a competition potentially between equity goals. And just as an anecdotal thing, prior to going into academia at the beginning, I worked at NCQA and NQF and various CMS contracts, and the priorities definitely shifted between, say, the Trump administration and the Biden administration, and the focus became very much on like the white rural population, or just the rural population really, and try to downplay some of the focus on racial disparities or racial equity. So anyway, all that is to say is there can be competition among equity goals, and we don't often discuss them. But these complexities should be considered in the early design phase of quality measurement systems. And so it's complicated, but we have tons of people that we have to think about this. So there is one example that I wanted to share just to make what I'm saying a little bit more concrete. There was a paper that came out in Health Affairs last year this time. It's called A Formal Framework for Incorporating Equity into Healthcare Quality Measurement, led by colleague at Rand. I'm actually collaborating with him on the project that I'll talk about in a moment. So the authors of this paper, I highly recommend you check it out, simulated 4 possible quality improvement scenarios for different patient groups. And so what I mean by quality improvement scenarios is by adjusting the way that the performance measure is calculated, the expectation, there's a different expectation on what improvement will look like. So in this case, each scenario, they simulated the effect of quality improvement if a health system were to try to increase their colorectal cancer screening rate within one patient group, say focusing on a particular demographic, by 5 percentage points. For example, you may want to increase the rate by 5 percentage points among your rural patients. And so this is an example from the paper. So this chart offers a kind of a visual breakdown of the colorectal cancer screening measure that I just mentioned, comparing. So in the first panel, you have overall quality. And so, well, first I'll just go through. So there's overall quality. The second panel is stratification, which is, I mentioned what that is already. And then the disparities, which is kind of the percent differences in rates or absolute differences in rates. And then he introduces in this paper a equity weighting approach, which I'll talk about in a second. So the bars that extend below 0 indicate that the relative contribution to the negative portion of the disparity calculation is there. So that would be in the disparities column. So first I'll go through. Oh, I should also say, in this, they used, so this was 2017 data from Medicare claims to calculate the colorectal cancer screening rates across health systems. So in the first column, so which is the overall panel, in this section, it's aggregating performance across all groups, not highlighting any particular disparity. So this is the status quo. This is what we do and have been doing. The second panel, we break it down by specific demographics. So we have Black, white, metropolitan, and rural. And so this approach identifies variances in inequality that might be masked in the overall data, which is what we've always talked about. So for instance, it appears that the metropolitan populations, both Black and white, receive relatively better care compared to their rural counterparts when looking at the screening rate stratified this way. Then we have the disparities panel. So this focuses on directly the differences between demographic groups. So this is, again, as I mentioned, the absolute differences in rates. So performance rates, if I hope you're tracking. So you in this case, you can notice how pronounced when comparing race and rurality, and the kind of the contrast between metropolitan and rural outcomes. So again, this is also, I mean, if you've probably attended other talks where they talk about how you calculate or characterize a disparity, it makes a big difference in thinking about the magnitude and the direction of the disparity. And so I'm not going to go into a lot of detail because I think it would get too technical, but there's instead of doing it these 3 ways, which is what we've been doing, the author of this paper proposes that we do an equity weighting approach, which actually builds in our policy goals for improvement in the specific group. So the method actually adjusts the quality measure to emphasize equity, which weights the scores to highlight disparity. So for groups where we expect them to perform, to have, say, lower colorectal cancer screening, we're going to provide greater incentive for that provider or that, the health system or health plan to improve within those groups. And the goal here is to do this, to weight it in a way that we don't reduce quality for groups that are considered socially advantaged. So we don't want to see an improvement in the rural population at the expense of the urban population. And so what was very cool about, what was very cool about this paper was the simulation, which I attempted to replicate in what I'm going to show you in another context. And so looking at the authors of the paper looked at two different approaches. So a basic incentive approach in which, patient groups would, in order to maximize their quality scores, providers trying to model what exactly the outcome would look like under each one of these different performance measurement scenarios. That's a cleaner way of saying it. And so, and again, this is trying to see how much it would, if they were trying to improve the rate within each one of these subgroups by 5 percentage points, what would be the optimal strategy? So they used optimization. What would be the strategy that would make the most sense to get them the best ranking? And so in the first case, we see, because of the sheer size of the white population and the urban population, that they get a better bang for their buck by focusing on the white and metropolitan population. So you could say that that is the status quo. And then if you look at the average stratified quality, so again, stratification, even with stratification, because of the relative differences in the sizes of these populations, it still makes more sense for the system to focus on the white and urban population. If we look at the average disparity, so we're looking at the absolute difference between the groups, and we incentivize them to try to improve, then we see in the simulation models that we see a increase among the rural and Black population, but a decrease at the expense of decreasing the rates of screening within the urban and white population that we don't want. And it's almost like a canceled out. And then there's another approach here in the paper where they try to do both the status quo, which is just looking at you continue to incentivize overall improvement, but you add on an incentive for reducing disparities. And in this case, we do see a significant increase among rural and the Black populations, but it's still not the great, it's a greater increase compared to the white and metropolitan. Now, which is, but it seems like the rural population makes out the best in this case. The equity weighting score doesn't reduce, performance among the white and metropolitan group or urban group, but it does significantly improve among Black and rural populations. So I hope you're following me. But the bottom line is equity weighting is an approach that we should consider in performance measurement to try to pursue the policy goals that we want to pursue, because no matter what, however we reconstruct the measures, we are implicitly, at least, building in certain incentives for improvement. And so we should be thoughtful and explicit about the incentives that we are introducing. So before I move into part 2, which is the kind of the simulation modeling that I've been doing with Dennis at RAND, and under the pilot, I wanted to kind of just stop to see if anybody had any questions, and also check the chat again. Where am I?
Dr. Golden has a question.
Oh, great.
Yeah, so one question I have is that you mentioned that there's a lot of work at CMS around this right now, which there is, but there's also work at the Joint Commission, around this as well, for hospital accreditation. So it doesn't count in the accreditation process yet, but it's one of the things that's being asked at visits, so it will at some point. And then there's like leapfrog, and there's the other reputational measures, and they're not all aligned. Some of them are. I feel like some of the CMS and Joint Commission are maybe more aligned than the others, but it can be very confusing for systems or hospitals that are trying to pick their one equity measure to focus on. What do you think the path forward is for there being some alignment in that arena?
Yeah, that's a good question. So I know that the Joint Commission and I think Leapfrog also, they're both measure developers for CMS. So there should be following CMS's blueprint for quality measure development. But at the same time, these measure developers have a lot of discretion within their own settings and the data sources that they're using. That was the whole, this is my bias having once worked at NQF. And I think this was their goal, was to try to harmonize. That was the main goal of the organization, is to harmonize measurements so that we're all moving in the same direction on any given topic related to healthcare quality. And so I think that contract is now with Battelle, but I don't know if that's just for the measures that are going into the payment programs. But I think that's probably the only way, is that the systems, people have to talk to each other and they have to come up with a plan to select the same types of measures that they want to be, held accountable for, and so that they can also compare themselves to their peers and have coherent conversations. So yeah, so I think maybe if that answers your question.
Yeah, that
It
sounds like
looks
there's more work to do.
Yeah.
To do that.
Definitely, yeah. And again, I think that we're a long way from that, because we just don't even have many, we don't really have measure. I didn't put this in the deck. One other thing I'll say, I didn't put this in the deck, but so CMS did do a the Assistant Secretary for Planning and Evaluation, ASPE, commissioned a report in 2021 looking for health equity or healthcare equity measurement strategies. And they looked at thousands of measures out there, and they only found about 10 approaches. And of them, maybe one or two of them were actual measures that could be used as concepts to then be translated into a program. And that measure was developed by RAND under a CMS contract. So it's so yeah, there's a long way to go. Siobhan?
Yeah, Siobhan. Siobhan Laird.
Hi. So I have I guess maybe it's the same answer. My question, or maybe just something for consideration, is that a lot of times hospitals are just working towards whatever CMS is telling them they want. And so we're not really set up to, like, I love this measure, but if I bring this to my system, there's no one to calculate it. And so it would be great to kind of understand where's that middle ground between stratification, which is what CMS has told them that they want, and so that's what folks are running, and something like this, an approach like this, because I think this gets us closer to actually addressing underlying disparities, but it's hard for me to sell this internally.
Oh, yeah, I think this has to come from CMS, given that like this is going to be something that maybe the researchers will have to demonstrate the utility of, and do this persuasion, maybe do a demonstration or something like that. I think we're pretty far off, because we're just trying now, just in the last few years, that we're trying to get the stratified reporting more consistently. I mean, even in CQA at the health plan level, they just, within the last 4 years, are now requiring health plans to report measures by certain sociodemographic characteristics and only for a subset of measures. And that's just stratification, which I think is important, because at least we know the areas that need improvement at a level that's low enough or close enough to the patient that we can do something about it. Because when we have, we're describing healthcare disparities at the country level or the state level or even the county level, it's hard to know who's responsible for those patients. And so anyway, I think maybe this is maybe showing a path in a way. But first we need to probably pick the lower hanging fruit, which is just to get the stratified reporting. And then eventually, with enough evidence, CMS might say, all right, now let's try to, in the payment programs themselves, let's try to do some of this weighting so that we can create the right incentives. It looks like I saw something in the chat there. Oh. All right. Okay, I will keep moving.
Mm-hmm.
All right, so I am going to briefly walk through this, and I tried to keep this as high level as possible. So the goal of this study, which is, I think we've kind of set the stage for a little bit of what we're trying to do with simulations. So the goal was to try to understand how different ways of measuring quality can lead to different incentives for improvement among various subgroups within, and in this case that I'm about to show you is for Medicare Advantage contracts. And I won't go into too much about what Medicare Advantage is, but just as I mentioned, it's, the private alternative. And over 50% of Medicare beneficiaries are now enrolled in these private plans, which again are paid by paid through capitation and all of that. So as the population ages and as this becomes an increasingly attractive option, we really need to understand what's going on here and making sure that those oh, I should also mention, I think it's the fastest growing group of demographic within Medicare Advantage are Black and Hispanic Americans, as well as people who are dually eligible for Medicare and Medicaid. And we're still trying to figure out why some of that is. Oh, and I also, on a side note, would love to have a conversation about Kamala Harris's new plan around, adding home health to Medicare and how that would, I don't know if that can be the subject of a future session, but very, very exciting and long overdue. So let's just quickly talk about the objectives. So this is a what-if analysis to try to compare how different quality measurement approaches impact contract rankings. So at the beginning, I told you that, again, performance measures are used for rankings. And so they're always trying to adjust their relative positions to their peers so that they're eligible for bonus payments or, money that's available isn't taken away. In this use case, so I previously was talking about, I should have said health systems in that last paper and colorectal cancer screening. This is focused on the HEDIS measure, statin therapy for patients with cardiovascular disease. And this is a oh, Olivia? Did I just see someone? Oh, sorry, it just popped up. Thought it said a hand. And so we know that the uptake among several groups, many socially at-risk groups, is lower of statin therapy, and it's really an important medication. And so in this, I'm just presenting the overview. And so we simulated data from 10,000 contract plans, and we looked at the percentage change in the uptake of statin therapy under different measurement approaches. And so we tried to simulate, we introduced different types of variabilities in the scores and to try to mimic what a real world situation would look like. And so I guess I should also say in the data, it included baseline quality scores for 4 distinct beneficiary subgroups. So we looked at, going back to what I said about the Health Equity Index, where they're focused on dually eligible folks and people living with disabilities. And so we looked at the combination of people who are dually eligible with a disability, dually eligible without a disability, dually eligible non-duals with a disability, and non-duals without a disability. And so these scores were based on the realistic distribution of values reflected in known disparities in statin therapy uptake. So if I said that too fast, again, we're focused here in this study on duals and the disabled and non-disabled populations. So what did I find using kind of a similar simulation approach? So the overall measurement approach, which is the status quo, we found sort of negative percentage point change for dually eligibles with disabilities and non-duals with disabilities. So for the more disadvantaged groups and under the status quo, we observed what we thought we would observe, which is, disparities. And then we tried the equity weighting approach, where we also, shift the focus towards the historically marginalized groups or vulnerable populations that might obscure overall performance. We saw a slightly non-duals without a disability experience a slight negative impact, but there was greater changes for the duals with disabilities. And then, we had a disparity measurement approach here where, we saw improvements across all subgroups. So this was the essential, I should have just showed the numbers. So these numbers represent the simulated percentage point changes in quality performance for different subgroups of MA enrollees under these 3 different scenarios. So the percentage point change refers to the difference between the baseline quality score for a subgroup and the quality score after applying the hypothetical scenario. And so this change is expressed as a percentage of the baseline score. In this case, the numbers are that are negative. So yeah, the numbers that are negative, this indicates a decrease in quality performance for these subgroups under that scenario being analyzed. And then, so for example, a mean of negative 0.09 here in the dual with disability group means that on average, the quality score for this group decreased by 0.09 percentage points in this scenario. So it was actually is what we expected. It kind of looks similar to the previous but there's a lot of the previous study, but there's a lot of kinks to still kind of work out, and we're trying to base our simulation on real world data. So I'll briefly talk about what that means. So we have access to all of the Medicare claims for 2019 for Medicare Advantage enrollees. So we have the Medicare beneficiary summary file, for those of you who are familiar with it as the MBSF. And in this this scenario where we try to compute, we try to get a sense of how many people are actually eligible within these health plans for this measure. We found we included beneficiaries if they were alive for an entire year, if they lived, of course, in the United States and were continuously enrolled in Medicare Advantage for 12 months. And then we use the same file to identify those characteristics, again, whether they were dual or had a disability. And now I'm showing you real data right now. So this is the distribution of contract plans. So when I say that there's the insurer, and the insurer has multiple plans within it and contracts. And so people are associated based on where they live with different contracts. And I won't go into how Medicare Advantage is billed, but her bid for how they bid for those contracts, but it is relevant. And so these are the total number of contract plans. These are real plans with these various subgroups. And so they had to have at least 30 beneficiaries in each subgroup in order to be included in this sample. And as you can see, these plans account for millions of beneficiaries. And as you can also see, the largest group are those who are non-dual and have no disabilities. And then I put different plan types. You could ignore that for now. I also broke it down just to get a sense of, although in the simulation, we're not looking at these other demographic characteristics, but we just wanted to get a sense of the kind of racial composition and where these people live. And we did break it down by the, what are the demographic characteristics of these 4 subgroups? And, their months of eligibility for Medicaid. I'll glide by that. And so this is the more detail on the simulation. So again, we generated 10,000 contract plans, which represent a diverse set of Medicare Advantage contracts, like I showed you before. And so in a little bit more detail, each contract plan was assigned a unique identifier to track individual contract performance across different scenarios so that we could ensure that we accurately measure changes in outcomes, both within and across beneficiary groups. Basic setup, and then a little bit more information here. So these were the 3 performance measurement scenarios, and I think I went over this a bit more. I'll stop here for a moment and just say that, so for the equity weighted score, which is sort of what we're advocating for maybe in a future state under certain circumstances, the weights are also a kind of a normative or a subjective choice. And so I think in this case, we would need probably, in typical fashion, some sort of expert panel to come together to decide on what the weights should look like, in the same way that we weight other types of measures in the healthcare system, where sometimes we have what are called composite measures, which are measures that are sort of, for instance, for like hospital-acquired conditions, it might be made up of several different types of conditions. And those individual indicators that make up the larger measure are weighted differently based on their importance. And so we'd be doing something similar in this regard. So these were the 3 scenarios, and I won't belabor the point there. And so this is kind of just an example of in the simulation, we had to introduce some sort of random noise, which would basically creates various swings in performance between each one of these simulated contracts. And so again, building in human assumptions and based on what we know from real world data, we assume that, the rates are going to vary within the dually eligible and disabled population more widely, where we expect to see lower scores. And then we're going to see less for the non-duals and non-disabled because they have more resources, and don't have functional status problems. And so this is more about the kind of the score creation, but this is all to say that, we just a little bit of a peek into what's under the hood. And as I mentioned, I did mention the measure that we're using is statin therapy for patients with cardiovascular disease. I just pulled this directly from NCQA's website, which just shows you sort of the overall, this is how they report overall performance across health plans by type. So we have commercial HMOs, commercial PPOs, Medicaid, Medicare, and different types. And as you can see, it's relatively high, the overall score. But again, as you all know in this group, once you stratify, you start to see much more variation within plans in the rates for various subgroups.
Andrew, could I ask a quick question about this measure? So it's like, it's people who have the, ASCVD and who have received and adhered to statin therapy. It's like, do they mean that the prescriber has continued to prescribe the statin therapy? Because how do you know whether somebody adhered to the statin therapy or not? I mean, they're not actually using medication refill data, are they?
Yeah, they are.
Okay. All
I
right.
know.
Just kind of interesting.
Yeah, they're using prescription fills. And it's actually, I'm still trying to calculate this manually with a programmer in the claims. And it is very difficult to track the number of days because this is a simplification of this measure's definition. But there's overlap in days, there are multiple fills on the same day or in the same week, and there's lots of issues. And then as you're pointing out, filling it doesn't necessarily mean that they're adhering.
Okay. But it is using medication refill data though.
Yes.
Oh, okay. So that's at least it's not just using prescribing data from the clinic, but
no. It's fills. Yeah, it's prescription fills data. Yeah.
Okay. Good. It's still not perfect, but better than
definitely better than prescription.
Yeah.
Yeah. All right. And I just have a few more slides here. And then just to give you a sense, again, I think I've mentioned this, but we're looking at the percentage point changes in performance. So we're looking at, so the percentage point change is calculated as the difference between the new score generated under the scenario and the baseline score divided by the baseline score and multiplying by 100. So a fairly simple formula. And so an example might be, if the base score for a dual with a disability group was 50, and then the scenario score increases it to 55, then the percentage point change would be 10%, right? But what we observed was actually very much smaller changes in percentage points. And so this is the same chart that I showed you at the beginning. So I just showed you the results at the beginning, and I'm showing it to you at the end. In that the results seem to reflect mostly what we think, but this is, again, a work in progress, and we'll see what we end up with. We're still trying to calculate the measure accurately in the claims in order to update the simulation. All right, my last slide. This is kind of the next steps for this work. So again, we want to apply the real updated data to the rates across subgroups, so our assumptions are accurate. And we're going to do lots of sensitivity analyses. So we want to test different weighting schemes, higher, lower. The baseline quality scores again will be better once we're basing it on real data. And again, we're going to try to come up with, alternative methods for calculating the disparity. We might test the impact of extreme differences in subgroup population sizes at the contract level. So we had a minimum for the denominator of 30, but that might not be reliable enough. So we may be including plans that don't make sense to include. And then ultimately, and I think many people are probably going to do this and maybe even beat me to it, is to try to calculate the scenario actually using the CMS Health Equity Index, which is slated to be included in the CMS star ratings in 2027. And so very interested again in continuing to do this for different measures to try to see how, balancing various equity measurement approaches leads to different types of rankings among plans, and what scenarios could at least hopefully lead to the greatest reductions in health disparities or healthcare disparities. All right, did say a lot. Thank you for sticking with me. Oh, wow, a lot of you are all still here.
Yeah. No, we're all still here. A lot of us are still here. This is really, really fascinating and important work. So thank you so much for sharing with us. I think that I'm so glad that you took the time to share this, because I think a lot of people get this idea that, well, advancing health equity or advancing equity in healthcare is just basically you just take your regular quality measures and you just stratify them, and and you just look for improvements in those groups, and that should be it, and and then also I think not only how you measure it, but actually what do you do to try to address these issues is a lot more complex than a lot of people think. So I appreciate you sharing that, and sort of making, I mean, we're kind of members of your community, your research community, but I think still there's a way that recognizing the complexity of these issues and all the different sort of competing issues that are playing into how we prioritize what we're going to do and how we measure the effectiveness of what we do is so important. So I'm just cheering
Thanks.
you on. And I guess the question that I will ask you is about how you engage with the people that you are studying. What has that process been like for you in terms of helping you formulate your questions that you want to address? And then similarly, once you have results, in sort of sharing that back and how, making sure that it gets used. So it's a little bit complicated, but yeah, just if you could share a little bit about what that is like, because I know that this work does involve kind of having people really take a look at what they're doing, and it can be challenging for people to feel that someone is sort of studying what they're doing and putting a value on some of the performance issues that they're observing. So
Yeah, no, that's a really good question. I think the hardest thing I will say is finding the right funding for this type of work, because it's really something that is usually initiated by, at least from an academic institution, it's tough to do. But what I try to do is continue to stay plugged into some of my old networks. So, well, and some new ones that I've built. One is, I'm on a advisory group with NCQA, and so I try to keep there. And I'm now doing some work with Mathematica. I've helped, try to insert some of the, I was developing a training, helping to develop a training for the folks at Mathematica who are developing measures for CMS. So I think that goes a long way. At least they're considering all of these things within the limitations that they have within their contracts. And so, yeah, I tried in RAND again, I'm trying to collaborate with the folks that are doing it. But it is tricky, given from where I sit anyway, to do this work. It's much slower than I would like. But I think, you know, once I do get into a position to share this more publicly, I would probably lean on folks like you to try to figure out some of the right people to reach out to. And I've also thought about writing some, you know, perspective pieces and that kind of thing. That might be a way to have something out there in print and faster.
I think that's really important. And I think, like, for example, that paper that you shared that was in Health Affairs does really bring attention to the issue by people who are in a position to use this research. I think you would find really willing collaborators in many of us who do clinically oriented health equity research, in that we are actually interested in looking at, improvements in disparities and as a result of, the trials and the different interventions we're testing. And so there's, I think, the opportunity there in some of our work that tends to be funded more by some more traditional sources such as NIH and AHRQ and PCORI and things like that. So please be sure to reach out to us, and we will keep you in mind as well, because we do study a lot of the issues you're looking at as well.
Yeah, no, I'm really excited too to be a part of this group because there's so many names here that I don't recognize. I'm like, I should. It's like this is definitely the community. So
Are there any other questions? I see some comments in the chat. Kays Adams talking about how great it is to use disparity measurement. Let's see, to assess health equity, is CMS or other organizations creating user-friendly tools or methods to broadly share methods to measure disparity or to identify inequities between groups for health equity purposes?
yeah, so I mean, there is CMS, the Office of Minority Health is doing a lot, which is great. So they also have a disparities mapping tool for Medicare where you can actually go in and plug in your location and see, you know, what hospitals, for instance, are within your area and see, and you can break the rate. It's another kind of like stratifying tool, but it is useful, and they're always coming out with reports as well. And especially their, I think maybe at least biannual report on health disparities. So within many of the measures that we talked about today, as well as many more.
Yeah, lots of people putting positive comments in the chat, and a recommendation to connect with CMMI. That's right, they do fund projects that would probably be interested in looking at tools like what you've just shared with us. I see Jordan has her hand raised. Jordan, do you want to?
Yeah, thank you so much. And this was fantastic. Really enjoyed it. I was curious to hear your thoughts on the Health Equity Impact Index, and sort of a twofold question. One being, if it's going to be impacting 2027 star ratings, does that mean starting in 2025, MA plans will be starting to feel the pressure to take action on that index because of the way in which, is it like 2 years prior impacts 2027 year?
So yeah, so actually right now they're already, well, they should, but I don't know if they are. So the performance period for 2027 is 2024 and 2025. And I am trying to plan a project with a plan in California. And I've asked their data science team and some of their leadership, and they're not really, I mean, they have so many priorities that I don't think they've gotten around to this quite yet. So I think it's probably going to hit a lot of plans when it happens. They'll see, you know, whether or not, you know, it may become a priority once the reporting starts, but I don't see, at least that's a N of one. But maybe there are plans that are more proactive in trying to see, especially the really large plans where, you know, there are many millions of dollars at stake for, you know, that they could potentially lose or not get. But yeah, I imagine it's going to look very different across plans. It would be great to have a survey or something and similar to, so I see like maybe KKF does this, I don't know, but KKF often surveys Medicaid directors, and it would be great to have a survey of even, folks at health plans that are working on trying to reduce disparities and what their initiatives are. So it would be great to get funding to do something like that. And maybe partner with NCQA or something, some other organization.
Yeah, that's really interesting. And I'm curious your thoughts on sort of what those initial first steps should be for plans who are starting to move into that space and think about those items.
Yeah. So I think the first thing is, so every plan is going to look different. So some are going to be doing really well. There are plans that are even focused on dually eligible beneficiaries, so they may be excellent because they have systems in place. I don't know. I think it's also going to look different by the where folks are. I don't and kind of the root causes of what the disparities are locally. So I think there's probably many answers to that question, but there is the first, you got to measure it, and hopefully you're measuring it already. Like I know Blue Cross Blue Shield of Massachusetts has been doing a lot of great things for at least the last 7 or 8 years to try to stratify all of their measures to identify where gaps are, and they have initiatives going on in various places within the state to try to improve their measures. And so, and I do think that their strategies are probably more local. And then there's also the limitations in what a health plan can do. So some of it is some care coordination and case management. Some of it's marketing and or tailored. Oh, actually, I am moderating. Is it today? Today's Wednesday. No, yeah, Friday. Hopkins Business of Health Initiative. We are inviting a group of health plan representatives and folks from the Medicare, represented from Medicare Rights organization to talk about plans that are tailoring their benefits to specific demographic groups. So like Asian Americans, veterans, women, LGBTQ plus, gender affirming care, and trying to get a sense of their motivation, the challenges. And so that could be, another conversation where I'm actually going to ask them, what are you doing? Why are you doing it? What changed you? What's your theory of change?
Awesome. I'm going to look at that. Thank you.
That'll be very interesting. If you can share that information with me, if that session is open to, a broader audience.
Oh, it absolutely is. Please come. I will, I'll send it to you right after this, the registration.
Yeah, that would be awesome.
You can watch it while you're having lunch. I know it's Friday, but it's early.
Yeah. I think I've been fortunate enough to be a part of at least one of those sessions in the past. And I see Kathy McDonald is online, who's also.
Oh, hi, Kathy.
Yeah. Great to hear about. Actually, I actually had a question too.
Oh,
Yeah,
sure.
yeah. So this is great work, Andrew. It's so good to see it some more. So you were talking about how different weighting schemes can work, and since you're going to be talking to all these folks on Friday, I'd be really curious, first from you, but also from them, whether there's weighting that moves them more likely in the direction that would be possible to be more aggressive about trying to close the gap that exists. I mean, like that's your whole thesis, is trying to figure that out. But there's so much, like in terms of what the limitations are of the data and what the limitations are of like how people will really respond. I'm curious though, kind of more ideal world, how would you want to have the weights, be like reflecting where the harm really is? Like what would you think of as harm weighting, if that makes any sense?
Yeah. I mean, I guess that is the goal, is to try to. So I guess there are two things. Is like getting the weights right so that I guess they're related. How do you weight it to match the burden? And also both provide enough of an incentive for improvement, because I
Mhm.
think this is also another
Yeah.
big issue, is like increasingly the health system is being privatized. And so these companies, I mean, there's certain
Yeah.
things you can't say on the webinar on Friday probably, but there,
Could say here.
you know, there's an, you know, there, no margin, no mission, right?
Mhm,
So,
mhm,
like how do
mhm,
you how do you create a strong enough incentive? And I think that the
mhm.
dollars behind it at risk, or the bonuses, the rewards,
Yeah.
have to be proportional with the level of effort that we think will need to be expended in order to close
Uh,
the gaps. And then where do we think that health plans, if that's the kind of accountable entity, have the
mhm,
most leverage for
mhm,
doing that? Because then they're also sort of having to
mhm.
lean on their providers, or, you
Yeah.
know, so they're limited too in their capacity, because they're not the ones doing the colorectal cancer screening.
Mhm.
So yeah, so it's a tricky thing to balance.
Mhm. Yeah, I'm glad you could say that here. But
Yeah.
that makes a lot of sense to weigh both sides of the equation, what that sort of actionability is and downside risk of them not feeling incentivized when you
Yeah.
could have incentivized them. Yeah.
Yeah. Because we might find that's actually going to be something very interesting to look at when it is included in the star ratings. Like, does it
Mhm.
actually drive performance at all? I mean, I'm sure there's
Yeah.
lots of people who are going to jump on that research question. Did it do anything? We spent all this time
Mhm.
and resources, and it's by the time we're able to really evaluate it, it's going to be probably 10 years in the conceptualization and rollout. So,
Mhm.
yeah, thanks for the question. That's good.
Sure.
And then it looks like somebody else, the general question, somebody, how do you ensure you keep up with the latest recommendations or info from CMS for a general, for general health policy? It seems like they're different. Yeah. Oh gosh, yeah, it is really hard to keep up to date. I think this is the type of forum, like getting more into these types of forums where you can get people who are closer to some of the issues, or maybe working on it, and they can share rapid fire the different things that might be going on, is probably a better way to go. I have a really hard time with all the different listservs and the mailings that come out day to day. So I miss things all the time that way, unless I'm specifically looking for it. I have set up some like Google alerts, but those aren't that helpful for me. So I find, you know, finding a certain set of reoccurring kind of meetings where people can come and speak to this is probably the more way, the way that I find out about things. For instance, I was interested in, I found out late, 2 weeks late, but luckily I joined a call where they told us about the CMS discontinuing access to the Medicare and Medicaid data, like the physical assets, that rule that was passed. I think it's still in process, but that affects all of our grants, because, you know, a lot of us rely on the pre-existing data assets that we have in-house, and now we have to access it through the VRDC. That's a very specific example, but, you know, probably wouldn't have found out about it as fast as I did if I didn't join one of these types of calls.
Right.
And that's what research community is for. So yeah.
Right. No, and I really think there need to be more spaces where there's where we bring together the research community, the funders, and the people who are actually like implementing the work together, you know, because I think a lot of times the work is happening in silos, and that's one of the reasons why we are so late to finding out what, you know, what is going on or what's needed. And it hampers us in our ability to actually provide timely answers, you know, to
It
the.
would be, maybe this is a recommendation. I don't know if this already exists, but it would be nice to have, since CMS is right down the road, especially for
Mhm.
CMS, if we could have a representative. We have, I know they come in every now and again to give talks, but, you know, if we could have that more of a regular thing, and we know that it's going to be at this time every year, or a couple of times a year, where they talk about the priorities or how things are going,
Yeah.
that would be nice. I don't know.
we can work on it. We need to coordinate amongst ourselves too.
Yeah. Or even if it's just the director of the CMS Office of Minority Health or one of the deputy directors to come and speak once
Right.
a year would be nice, because then they're
Right.
keyed into everything else related to equity and
Right.
CMS.
No, I think you're right. And I think we did have her come and speak at the BSPH sometime last year. Not sure at the exact date, but I thought I thought it was last year. But
I think she's all LaShawn McKeever. I think.
yeah,
Yeah.
I think so.
Yeah. I think there's a new one now, so maybe it would be a good time to introduce.
Okay.
Yeah, I can't remember his name, but she's now at AHIP.
Will do. But anyway, well, this was really interesting and exciting, and glad to have you. Please come back again next month and or whenever you can. And those of you who are joining us for the first time, please sign up for the series, and we look forward to seeing you all next month. We have Dr. Maya Venkataramani, who is going to be speaking with us about her work, and I believe it's on sort of multi-level interventions that address families, to address health disparities. So I probably didn't say that as well as I could have. She was online. I see she is online, but we will be sending out information about her talk in November, and we look forward to seeing all of you again then. And until then, happy Halloween and go and vote. Yeah, may it all work out favorably in the best way possible. Okay, thanks everyone.
Thank you.
Okay,
Thanks,
bye.
Andrew.